Welcome to LG PathLab's monthly pathology webinar series. Today we have Dr. Clara Limbäck with us, who is Head of Neuropathology and Neuromuscular Unit at Imperial College Healthcare NHS Trust in London. Welcome, Dr. Clara.
Thank you, Lindsay, and thank you for inviting me to this webinar series. Good afternoon to everyone. My topic for this afternoon will be the integrated diagnosis of adult gliomas, and the presentation will be mainly case-based. I will, however, start with basic concepts in the diagnosis of gliomas. As you all know, we are now required, besides giving the more conventional and traditional histological assessment of tumor type and tumor grade, we're required also to provide the genetic profile in the diagnosis of gliomas, or more in general of tumors of the central nervous system, as for many of these entities now genetically are known. And already several years ago, it was proposed that in order to convey this message clearly, a layered reporting format should be used. And you will see some examples as I will be discussing today's cases. Although this often seems very complicated, the diagnosis of most glial tumors can actually be solved in an easy way, keeping in mind a few simple concepts. The first and most important one is that gliomas can be divided into two main groups, and these are the diffuse gliomas and the circumscribed gliomas. Diffuse gliomas are the typical CNS tumors of the adults, and in fact their incidence increases with age. They are almost always supratentorial, and malignant infiltrating tumors. And importantly, they have a tendency of to become more malignant over time. So even when they start as relatively low-grade tumors, as a grade 2, over time they transform into grade 3 and grade 4. Morphologically, they can show either astrocytic differentiation or oligodendroglial differentiation, and often we can find a combination of both cells with astrocytic and oligodendroglial morphology. The circumscribed gliomas are typical of children and young adults. These are usually low-grade tumors, grade 1 and grade 2, and they tend to be quite stable, so malignant transformation is rare. These tumors often also occur in the posterior fossa, in particular the cerebellum. They can be supratentorial, but the cerebellar location is the most frequent one. And the most common of these gliomas is the pilocytic astrocytomas. All the other entities are rare. Morphologically, they typically show astrocytic differentiation. Oligodendroglial morphology is rare in these tumors. However, sometimes they can be mixed glioneuronal tumors, so showing a combination of astrocytic and neuronal cells. And importantly, these two groups of tumors are also very different as one we expect from the genetic point of view. And so diffuse gliomas very often, in 30% of cases, carry mutations in the IDH1 or 2 genes. A much smaller subset, but well characterized, carry mutations in the histone 3 proteins, particularly in children and very young patients. While on the other hand, circumscribed gliomas carry frequently mutation in the MAP kinase pathway, and in particular in the BRAF, NF1, or FGFR1 gene. And we can now start with our first case. So this is a 45-year-old man presented with seizures. And was discovered to have a lesion of the right frontal lobe. which on MR appear to be localized in the cortex and subcortical white matter, with no evidence of high-grade features. He had a resection, and these are the histological images. So at low power, we see a lesion of moderate cellularity. I like to present with tumors. Often my students say it looks almost like a normal brain, just a bit busier. So the cells are quite blunt, and there is a fibrillary background. At higher magnification, we can see a combination of astrocytic features, so cells with abundant eosinophilic cytoplasm and long fibrillary processes, as well as in between cells showing cytoplasmic clearing, which is something that is commonly referred to as oligodendroglial morphology. There is no significant nuclear pleomorphism here, and no significant mitotic activity. If we look at another part of the tumor, we can see the cellularity is a bit higher, but still no mitotic activity. And we also see there is an increase in nuclear pleomorphism, which is something that points a bit more towards an astrocytic tumor. So here we said that it could go either way. The cells show both a combination of astrocytic and oligodendroglial features, but in a low-grade tumors, such as this one, finding significant nuclear pleomorphism is much more common in an astrocytic tumor, where oligodendrogliomas tend to be quite monomorphic. And in immunohistochemistry, the Ki67 confirms that this is a low-grade tumor. It is rather low, less than 5%. And then immunohistochemistry for mutant IDH1 protein is positive, confirming the presence of mutation. There is loss of ATRX expression. We can see in this capture here that the non-neoplastic cells, such as endothelial cells, are positive, but the neoplastic cells are negative. And that loss of ATRX immunoreactivity indicates the presence of mutation. And we can also see that there is on the right here, that there is diffuse overexpression of P53, which also indicates the presence of a P53 mutation. So the diagnosis here was of the histological diagnosis is diffuse astrocytoma. We know it is an astrocytoma because the tumor shows loss of ATRX expression and overexpression of P53, something that we do not see in oligodendrogliomas. The histological grade is grade 2. There are no adverse features, no high mitotic activity, no necrosis, no microvascular proliferation. And the genetic profile, which is a combination of immunohistochemistry and in this case, in next generation sequencing and copy number variation studies, confirm the presence of IDH1 mutation, ATRX mutation, P53 mutation, absence of codeletion, 1p19q codeletion, ruling out an oligodendroglioma. Remember, this is the defining genetic feature of an oligodendroglioma, and also showed absence of C, D, K, and 2AB deletions. Therefore, the final integrated diagnosis is diffuse astrocytoma, IDH mutant, WHO grade 2. And this is the most common tumor of adults, middle-aged adults. So I mentioned next generation sequencing. So in the majority of astrocytomas, actually there is no need to confirm the genetic changes with sequencing, as this can be easily assessed with immunohistochemistry, as I showed previously. Here is our case. Most IDH mutations, which is a point mutations, can be detected with the specific antibody. In about 10% of cases, astrocytomas or oligodendrogliomas, we will see later, carry a different IDH mutation that cannot be detected with immunohistochemistry. And so in cases in which the immunohistochemistry is negative, then we need sequencing of IDH1 and 2 genes. Most astrocytomas will also carry the ATRX mutation, which can be detected by immunohistochemistry, but in at least 10% of cases, astrocytomas are ATRX wild type. And about 50% of diffuse astrocytomas carry also the p53 mutation, but we still have 50% of cases in which p53 is wild type. And so in the scenario in which we have an IDH mutation, but no evidence of ATRX and p53 mutation, this can be either an astrocytoma or an oligodendroglioma. And so in these cases, we need also to assess the 1p19q codeletion. And a more recent concept, as we said before, these gliomas, diffuse gliomas of adults, tend to progress to become more malignant over time. And sometimes this can take several years, while sometimes it can happen quite quickly. And until recently, we haven't really had any marker that would predict a progression in diffuse gliomas. However, in recent years, several markers have been identified. And I will not go through all of them, but the most important one for now, because the most evidence we have, is the presence of a homozygous deletion in the CDKN2A and B gene. And this is why this is now routinely assessed, and it is expected to be introduced into the new WHO classification. So if an IDH mutant astrocytoma carries the homozygous deletion in the CDKN2A and B gene, it is considered a high-grade, grade 4 glioma, independently of the histological grade. In order to assess this deletion, it is necessary to use either molecular methods such as sequencing, or tissue method like tissue, immunohistochemistry, which could be assessed with the p16 antibody, is not reliable and therefore not recommended. And now let's move to case 2. You can already see that this is a very similar case. So again, we have a middle-aged man. Here is a 57-year-old man. We also presented with seizures, and was found to have a lesion of the left frontal lobe, which again on MR appeared to be located in the cortical and subcortical part of the frontal lobe. And again, there were no high-grade features. So histologically, this tumor showed a unique morphology, if you want. It's composed of monomorphic round clear cells with very irregular rounded nuclei. Morphology you probably all know very well. It is often referred to as fried egg type of cells, which is the typical oligodendroglial cell morphology. The cellularity is intermediate. There are no mitotic figures, and there is a characteristic chicken wire type of blood vessel network. Here we have another capture. In this area, the tumor is more cellular, and there is also an increase in nuclear pleomorphism. But there are no other adverse features, such as mitotic figures or microvascular proliferation or necrosis. So just an increase in cellularity and pleomorphism by itself is not sufficient to change the grade for this tumor. And immunohistochemistry here, again, the IDH antibody shows positive immunoreactivity, indicating mutation. Here, ATRX is retained in all tumor cells. There is no overexpression of P53. And then here, bottom right, the proliferation index is relatively low, around 5%. So the diagnosis, histologically, this is an oligodendroglioma, histologically grade 2. The genetic profile confirmed the presence of IDH1 mutation. We also detected a 1p19q co-deletion, which is the defining mutation of oligodendrogliomas. And most of the times, tumors that show such a beautiful oligodendroglial morphology will be co-deleted. There's a very good correlation between oligodendroglial morphology and the presence of co-deletion. It's a bit more problematic in the mixed tumors. As an example, if you remember the first case in which the cells showed a mix of astroglial and oligodendroglial morphology, those can really go both ways. But when the morphology is predominantly or exclusively oligodendroglial, these tumors are always co-deleted, essentially. And also showed the presence of a third mutation, a CIC mutation, which are common in oligodendrogliomas, and therefore the final integrated diagnosis, in this case matching the histological one, is of an oligodendroglioma IDH mutant 1p19q co-deleted, WHO grade 2. Next case. So case here is a 49-year-old man, which was diagnosed in 2007 with an astrocytoma grade 3, underwent surgery, which was followed in 2013 by chemotherapy and radiotherapy, and now on imaging showed sign of progression with contrast enhancement on MRI, and had a second resection. So now here we have to be a bit careful, because if you remember, I said in 2007 he was diagnosed with a grade 3 astrocytoma. And you have to remember that the classification has changed since then. So we often, when we see recurrence, we have to review all the cases. The classification changes in comparison to the original one. Now, if we look at this area of the tumor, here we have again a tumor of moderate cellularity. Here we can tell it's an infiltrating type of diffuse type of glioma, because we can see neurons. So the tumor is growing in between the background of CNS parenchyma. And we can appreciate, as compared to the first two cases, an increase in nuclear pleomorphism. And here, again, we can see the tumor infiltrating the CNS parenchyma. And we see, similarly perhaps to the first case, that there is a mix of cells with oligodendroglial morphology, the one that we said is the fried egg morphology with the cytoplasmic clearing, as well as cells with more astrocytic features, as we see, for example, here. So more eosinophilic cells with long fibrillary processes. And here we start seeing another important feature, which is proliferated blood vessels. Remember that microvascular proliferation doesn't mean only that there is an increased density in blood vessels. We have to see endothelial proliferation, so multilayer endothelium, in order to call it microvascular proliferation. And here is still very mild, very focal. Also remember, this tumor this patient underwent radiotherapy, so there are also radiotherapy-related changes of the blood vessels. That's, for example, the thickening of the blood vessels. Here, this could be treatment-related. And here, more convincingly in this capture, here the cells show clear-cut astrocytic morphology with abundant eosinophilic cytoplasm, what are often called gemistocytic astrocytes. And we also see more convincing microvascular proliferation with multi-layered endothelium. And just focally in this tumor, just in one small area, we could see actually numerous proliferated blood vessels in this garland-like structure. So this is very focal, but it is of course very suspicious of transformation to a grade 4 astrocytoma. The other question that we have to solve here is because this tumor was classified in 2007, and because morphologically we see both oligodendroglial-like and astroglial-like cells, this could be either a high-grade oligodendroglioma or a high-grade astrocytoma. So here the immunohistochemistry shows again positive immunoreactivity for IDH1, indicating mutation. It also shows loss of ATRX. If we look here on the right side, we see that reactive cells of so normal CNS parenchyma, endothelial cells, inflammatory cells are positive, but the neoplastic cells in between are negative, indicating mutation. We'll see again overexpression of p53 indicating mutation, and we see a moderately increased, I would say around 10% here, of the proliferating index 67. So this immunoprofile of mutant ATRX, mutant p53 together with mutant IDH, one is not compatible with the diagnosis of oligodendroglioma, and the final diagnosis of an astrocytic tumor, high grade because there is microvascular proliferation. We could not see necrosis, but there was definite microvascular proliferation. So the histological diagnosis, glioblastoma, WHO grade 4. The genetic profile here confirmed the IDH1 mutation, ATRX mutation, p53 mutation, absence of 1p19q codeletion, so confirming this is not an oligodendroglioma. And the integrated diagnosis is glioblastoma, IDH mutant, WHO grade 4. So this that I showed is a typical case of progressing IDH mutant astrocytoma. When we have a de novo glioblastoma, so the IDH wild type glioblastoma, it is typically a high-grade tumor throughout. But when it's a low-grade glioma, an astrocytoma transforming into a high-grade, what we see is this foci of mixed lower-grade and higher-grade areas. An important change we anticipate in the new classification, and these tumors will not be called glioblastoma anymore. Many of you probably know them as secondary glioblastomas, the IDH mutant glioblastomas, because they arise from lower grade astrocytomas. And they will now be called astrocytomas IDH mutant grade 4, just to separate them completely from the IDH wild type GBM, which is a much more aggressive tumor. So in the context of the grade 4 astrocytic tumor, an IDH mutant tumor has a much better prognosis than an IDH wild type. And this is why the proposal is to separate it completely. Let's move to the next case. So case 4. This is a 43-year-old man that presented with worsening left side weakness and headaches, and was discovered to have a lesion of the right parietal and occipital lobe, which on MR appeared to be a mixed lesion, partly cystic, partly solid. And the differential diagnosis radiologically included a solitary metastasis or a primary brain tumor. And in this case, because it was not clear, a specimen was submitted for intraoperative diagnosis. And here I have a capture of the smear on tall blue, which clearly showed that this is not a metastatic tumor. There is no epithelial morphology. The tumor cells appear glial with fibrillary features. And it's highly cellular, in keeping with a high-grade lesion. And this was confirmed histologically, where we have a first microphotograph showing a highly cellular tumor, which here shows mainly astrocytic morphology. The cells are spindled, they have abundant eosinophilic cytoplasm. In some areas, it is even more cellular. There is also scattered nuclear pleomorphism with bizarre nuclei, and we can also see areas of necrosis. However, this was a very interesting case. However, there were different areas in which cellularity was even further increased, as to show the feature of what is generically called a small round blue cell tumor. So it appeared poorly differentiated in these areas. And we can see here at higher magnification, we can see the scattered more polymorphic cells, and in between the high-grade poorly differentiated cells, as well as areas of necrosis, and also some microvascular proliferation. Microvascular proliferation here is quite important because it is a almost unique, I would say, feature of high-grade gliomas we rarely see in other tumors. So if we see a tumor with this morphology, which it could be more or less anything, it's really poorly differentiated, finding microvascular proliferations point strongly towards a high-grade glioma. And here, another interesting capture, in the poorly differentiated areas, we see a hint of rosette formation, as well as some nuclear molding, more in keeping with a primitive neuroepithelial tumor. So immunohistochemistry here confirmed glial differentiation. GFAP is positive in many of the tumor cells. The islands of high-grade small cell, the component are mainly GFAP negative, which is common for this cell morphology. And they show instead immunoreactivity for the neuronal marker synaptophysin, confirming some degree of neuroepithelial differentiation here. It also shows strong and widespread immunoreactivity for P53, strongly suggestive of the P53 mutation in this tumor, and also a very high Ki67 index. And so the diagnosis here is, because we have some areas that show clear astrocytic differentiation, is of glioblastoma with a primitive neuronal component. So this mixed tumor that contains some pinnet areas are typically gliomas that show pinnet differentiation, not the other way around. So pinnet tumors that show some glial differentiation. So hence the diagnosis here is of glioblastoma. The tumor is high grade, is a grade 4. And here sequencing showed IDH, an IDH wild-type tumor, confirmed as anticipated with immunohistochemistry, the p53 mutation, and also shows a mutation in the histone 3 F3A gene, and more specifically the G34R mutation, and also the presence of deletion in 19q and 10q. So this mutation is characteristic of a new entity, which is a diffuse glioma histone 3G34 mutant, which for now is still considered as a subtype of glioblastoma, but in the new classification will be separate tumor type. It is both clinically and also prognostically different from a glioblastoma, and this is why the separation. This is a tumor that is more commonly seen in children or young adults. Actually, this patient was a bit old for this type of tumor. It was a bit of a surprise, if you want. The prognosis is worse in an IDH mutant glioma, but better than in an IDH wild-type GBM, and this is why the separation. And interesting, it often contains these elements of poorly differentiated embryonal type of morphology, as seen in this case here. Next case, number 5. So this is a 23-year-old male with a short history of a loss of vision that developed over a month. He had, for instance, a CT, which showed a bithalamic lesion, which at the time was suspected to be neurocysticercosis. And this was followed by MR studies, which showed that this was actually a multifocal process with lesions not only in both thalami, but also in the cerebellum and brainstem. And so he had a biopsy, which showed the following features. So we can see here that we have a lesion that looks already at low magnification, neoplastic. This is not a reactive or infective process that was suspected in the first place. The lesional cells look quite monomorphic, and the tumor is only moderately cellular. And most importantly, it is seen diffusely growing in the CNS parenchyma. So this is a diffuse type of tumor. The morphology is deceptively low grade. Cells are quite monomorphic. They have long fibrillary processes, small nuclei. And this is something that is never seen in reactive gliosis. In reactive gliosis, astrocytes tend to have abundant plump cytoplasm and small nuclei. And here we have cells in which the nuclei are rather small, but very scanty cytoplasm, which is much more typical of neoplastic glial cells rather than reactive. And we can see the tumor cells, again, also here infiltrating around new neurons, confirming the infiltrative type, diffuse type of growth of this tumor. So a higher power, I could see in a small specimen like this, 2 or 3 mitotic figures at least. Here there is one in the middle, which it has been known for a long time that in small biopsies, astrocytic tumors, finding even very few mitosis are very suspicious for a high-grade tumor. And this was confirmed by the Ki67, which in this biopsy is at least 5% and probably more if we consider, given the fact that this is a tumor of relatively low cellularity. So because this was a small biopsy, I did not do much immunohistochemistry, but went straight for sequencing, which shows absence of IDH mutation and the presence of mutation again in the histone 3 F3A gene, but this is a different mutation as compared to the case before, which was the G34. This is the K27 mutation. So the diagnosis here is histologically, this is a diffuse glioma, probably astrocytoma, but I didn't confirm with immunohistochemistry. The grade is grade 3, as I said before. Finding a few mitosis in a small biopsy is not compatible with a diagnosis of a low-grade glioma. But because of the presence of this defining mutation, the final integrated diagnosis here is of diffuse midline glioma, WHO grade 4. So in the context of a diffuse glioma, located in the midline, and particularly in young patients, this mutation is always diagnostic of a high-grade grade 4 tumors. These are very aggressive tumors with a very infiltrative type of growth. Radiologically often correspond to what used to be a diagnosis of gliomatosis, or they are multifocal, like in this case here, even when histologically they look very blunt and very low grade. And these tumors are typically located either in the brainstem, particularly the pons in children, and in young adults more commonly, either in, as in this case here, in the thalami, the cerebellum, and sometimes also the spine. So case number 6. Here we have an older patient, a 71 years old man, with, again, a short history, 3 weeks of losing balance and confusion, and a history of lung carcinoma. On CT, a lesion was found in the left parietal occipital lobe, which appeared cystic. And the differential diagnosis at this stage was either of an abscess or, given the history of lung carcinoma, a solitary metastasis. On MR, this was confirmed to be a necrotic lesion, and a possibility of an intrinsic primary CNS tumor was also considered. And so he had again, a small biopsy of the cyst wall. And so this is the biopsy. It's essentially everything that we receive. Here at the bottom right, I didn't, because of them, I couldn't take the image of the whole tissue. There was a bit of cortex out here, but it was essentially normal cortex. The white matter underneath, which is this part here, is abnormal, is moderately cellular. And again, at higher power, we see, just like in the case before, if you want, very small, deceivingly blunt cells, which are not really compatible with a diagnosis of reactive astrocytosis. Remember, the initial diagnosis here was maybe an abscess, maybe a metastasis. So this could have been the gliosis around something that was not sampled in the biopsy. But this doesn't really fit the criteria for reactive astrocytosis. So these small cells with hyperchromatic nuclei and very little cytoplasm are more commonly seen in gliomas. Of course, here there are no other features suggestive that would help us determining the grade of this tumor. Their morphology looks astrocytic. And immunohistochemistry, the only helpful marker here really was the Ki67, which showed quite an increase in the proliferating index, considering that this is mainly a background of brain tissue and just a small percentage of what are suspect neoplastic cells. And the tumor cells, or suspect tumor cells, were negative for IDH1, ATRX appeared retained, so not mutant, and P53 was negative. So this biopsy here was then submitted for sequencing. And sequencing revealed, even in such a small specimen, with only a small percentage probably, which are very low tumor load, the presence of a mutation and a P10 mutation. This not only confirmed that this was not a reactive process, but also gave us some more important information. So histologically, this was diagnosed as a diffuse astrocytoma, grade 2. We couldn't see any high-grade feature in that specimen. But because of the presence of these mutations, in particular the third mutation, the final integrated diagnosis here was of a diffuse glioma, IDH wild type. This was confirmed with sequencing, but with a genetic profile of glioblastoma, so WHO grade 4. So we now know that in many low-grade gliomas that are IDH wild type, the final diagnosis is actually of a glioblastoma that has just been undersampled in the biopsy, but the common mutations of IDH wild type glioblastoma can be detected, and therefore this is often referred to as the molecular glioblastoma. And this will be also an important change in the new classification of gliomas. So it has been known for a long time, in fact, that particularly in older patients, a morphology of a low or intermediate grade glioma has to be correlated with imaging. It is crucial because often these are actually high grade tumors, but in which the high grade features are not seen in the biopsy. Or sometimes just because the biopsy is taken relatively early before the tumor develops all the full-blown morphological features of a glioblastoma. However, we now know that there are some mutations that are very common in IDH wild-type glioblastomas, and this can be used for a surrogate diagnosis of GBM when the histological features are missing. And these are the third mutation, as was detected in this case, the EGFR amplification, and the combined loss of chromosome 10 and gain of chromosome 7. It has to be the combination of both, not just one of the two. Here, it's important to be a bit careful, in my opinion, because while, for example, the EGFR amplification is truly diagnostic in a way of the IDH wild-type glioblastoma, no other gliomas show EGFR amplification. And the same for the combined 7 plus 10 minus. Where the third mutation is, you have to be a bit more careful because it can be sometimes detected also in other low-grade gliomas. In this context here of an older man and with the imaging, of course, the third mutation is sufficient to call it a glioblastoma. Even more careful you have to be in case of young patients, because in these patients, an IDH wild-type glioma can be a low-grade tumor. Not all gliomas in IDH wild-type gliomas in young patients are glioblastomas, of course. And here there is a group of indolent low-grade gliomas, which frequently carry mutations in the MAP kinase pathway, just like the circumscribed glioma, like the pilocytic astrocytomas have, that are IDH wild-type and have, of course, a much better prognosis than an IDH wild-type glioblastoma. And this brings us to the last case. case 7. This is a 46 years old woman, which presented with cerebellar signs of unsteadiness and dysarthria, as well as signs of increased intracranial pressure, headache, and nausea. CT showed a cerebellar lesion, and this was then further analyzed with MR, which showed a enhancing lesion in the central part of the cerebellum, mainly in the white matter. The differential diagnosis here included an inflammatory process, so perhaps MS, a lymphoma. She had a history of extracranial lymphoma, so this could have been also a CNS relapse of her lymphoma, as well as an intrinsic primary CNS tumor. So histologically, this was a very interesting case. Histologically, we have a fairly circumscribed, well demarcated from the cerebellum parenchyma tumor, composed of spindle cells with eosinophilic cytoplasm of moderate to high cellularity. I would describe this one. Here, for example, this is an area of higher cellularity. In which we could also find evidence of microvascular proliferation. And at high magnification, the cells show a spindle nuclei and a bit of a pyloid morphology with these long hair-like processes. And at higher power, we can see the relatively monomorphic elongated nuclei, but we can also see something else, such as this tumor has numerous mitotic figures. So these are the appearance of a high-grade glioma with astrocytic differentiation. In a slightly unusual site for a middle-aged patient, which is the cerebellum. Remember, the cerebellum is a typical site for tumors in children and young patients. And we were very spindly morphology. So immunohistochemistry here, GFAP confirms the glial nature of this tumor. ATRX, and I'll tell you in a little, just shortly after why I performed ATRX here, is weak, but it appears retained in the majority of tumor cells. And there is an significant increase in proliferating rate. The Ki67 is high. And there is no deposition of reticulin between tumor cells. In this case here, it was to rule out a possible gliosarcoma type of glial tumor, since of the relatively demarcated tumor and the very spindle morphology that was in the differential diagnosis. So the histological diagnosis here for me was of a glioblastoma, grade 4. We have the frequent mitotic figures, the high proliferating index, and the microvascular proliferation, with a genetic profile that is IDH wild type, P53 wild type, ATRX wild type. Now, in this case here, differential diagnosis was of a high-grade pilocytic astrocytoma, given the location in the cerebellum. You have to remember the glioblastomas and other astrocytomas in general in the cerebellum, they're quite rare. And she is still a relatively young patient. And so these tumors do not have a very well-defined genetic profile yet, but they can usually be detected by analysis of the DNA methylation profile. However, in this case, the test failed, probably because the sample was contaminated with normal cerebellar tissue, which often is problematic with this type of analysis. There were quite a bit of cerebellum, as you could see from the images before, mixed with the tumor cells. But copy number variation studies showed the presence of amplification of EGFR. And if you remember from before, EGFR is a mutation that is, the EGFR amplification is a mutation or genetic change, if you want. This is observed almost exclusively in glioblastoma. And so the final integrated diagnosis here is of cerebellar glioblastoma with a molecular profile of an IDH wild type GBM grade 4. This is a quite rare tumor. Remember, glioblastomas in the cerebellum represent less than 1% of all glioblastomas, and are often difficult to diagnose also because they rarely carry the typical mutation of the supratentorial glioblastomas. So in this way here, this was a surprise to find that this one actually contained the EGFR amplification. And this was the last case for me. Here, just quickly, because we touched a few of the points of the new entities and changes in entities that will be introduced with a new WHO classification. You can find more details about the proposed changes in this update of the consortium C impact that was published in 2020 by the International Society of Neuropathology. And thank you for your attention. I'll finish with a picture from back home a year ago when it was still possible to travel. As a wish that we'll be able to do this soon and maybe meet in person again. Thank you.
Thank you so much, Dr. Clara, for the wonderful presentation. It was very informative. And if our viewers have any questions, they will leave it in the comment box. And if possible, please get back to them ASAP.
Yes, thank you. Thank you, Lindsay.
Thank you so much. Thanks, Nia.
Thank you. Thank you, Dr.
Thank you.
Thank you.
Thank you.